So I'm going to do kind of a whirlwind tour of 15 to 20 minutes, where we've been, where we're going, and how we're thinking about things. So let's jump back to kind of the traditional AI era. So this is my soapbox at UCSF. So what is the problem we're actually trying to solve here? Industry, people have been coming at us with these solutions for a while now. But really, when we're trying to solve problems in healthcare, we have to think, what's the problem we're trying to solve? What are all the possible solutions, among which AI may be one? And then let's only proceed with AI if it's actually the right solution for this problem. The challenge is that researchers have historically taken the opposite approach. And so this is the sepsis mortality length of stay readmissions cow who's been over-milked by health AI researchers, because these are the problems that are actually really easy to answer. The answers are hard-coded in the EHR. It's easy to get the data. But the problem is these models haven't really had a lot of impact because they're usually, not telling me information. They're not telling me information I don't already know, right? And they're not doing things that make my day-to-day life easier as a clinician. And so that's why we haven't seen a ton of impact from this type of thing yet. Companies, unfortunately, have followed in the footsteps of the health AI researchers, and so this is just a short list of tools we've looked at from our EHR vendor, other folks have looked at. We've found that some of these models are very biased against vulnerable patient populations. We were actually able to outperform the length of stay model that was provided by our EHR vendor by using 2 dice. And yet these things are on the market, right? And so there's a lot of challenges, like historically, with a lot of these commercially available tools as well. There was a lot of hope for AI during the pandemic, and unfortunately AI continued to land with a thud. I think the AI models entered the academic literature at an unprecedented rate during the pandemic, but by the time they were actually reasonably good at identifying COVID-19 on a chest x-ray, we already had a PCR, so we didn't need that, right? And likewise, they wanted us to predict surge. We never had the right data to predict surge. And you don't have to be able to see this graph here to know that on the left is kind of overall, in the systematic review, overall performance of these models. Red is high risk of bias, and when these were even evaluated from an academic perspective, most of these models were found to be really biased and thus very problematic. So I sound like I'm all gloom and doom, which is not what I'm supposed to be as the Chief Health AI Officer, and I'm not. So I think there have been wins for traditional AI in health system operations. We've seen a fair amount of success in our Patient Capacity Management Center. It's our hospital command center. And there we have a couple AI models that are running, along with a lot of other data that's being shown to important people who make decisions about transfer center, admissions, et cetera. And we've seen improvement. We have decreased ED boardings. We have improvement in some of our metrics for throughput. But the thing is, I can't stand here with a straight face and tell you that it's our AI model that did that, and it's not just the fact that we now have the right people sitting in the room next to each other, talking to each otother. And so a lot of the times when we bring these tools into large systems, they're very complex, and there are definitely other things that are at play that mean the AI may or may not be helping as much as we think it is. So things are different now, and there was a landmark paper in 2017. It was called Attention is All You Need, and it basically described how we could now use these transformer models, foundation models, what we now call large language models, and understand the relationships between words and kind of derive meaning. And so with all the traditional AI that I was previously describing, basically what you had was technology that could take a basket of apples and oranges and separate them. Now you have technology where you can just describe what an apple looks like, and you can get a reasonable image of it. And likewise, you can give it a prompt or a query on ChatGPT and get a reasonable response. So where are we now? So basically what computer scientists have done is build everything we kind of know about a human brain with all the data we have into a computer. And we don't really know why it's as good as it is. And so I liken this moment to kind of when humans first discovered fire. So they could create fire, they could use fire, and enable a tremendous amount of progress, but nobody knew actually what they were doing at the time. And so I think that's where we are. And that was an AI-generated image when I described this to GPT. It's getting better faster than I ever anticipated. So I made this list in 2023, when we initially started talking about these tools, where I thought there would be opportunity. And I keep this slide in basically every talk because I think when you reflect on these domains, the amount of progress we've made, even in healthcare, in a very short period of time has been tremendous. Stat News is also tracking this, and so this is, as of July, they track the top developers, the top applications, the top sub-applications, and you can see these sort of follow what I had on the previous slide. So clinical documentation, patient and family communication, administrative support, and the top sub-application is clinical note scribe, which I think is what we all have the most familiarity with. So I'm going to talk about that for a few minutes. So Kaiser was the first organization to do this really at scale and publish it in the academic medical literature. And they published this in, I believe, January of this year. And they offer this tool to 10,000 physicians at once. Of those 10,000 physicians, about 3,000 activated it, said, okay, I'll try it. And of those 3,000, I think 960 or something actually used it regularly for more than 100 patient encounters. And they found some pretty good data here. So the quality metrics of the note themselves were pretty good. And there's some potential incremental improvements in some of these domains that we measure around time spent in the EHR and appointment-related activities. They saw pajama time, or time spent in the evening, was improved, and the time and notes in general per appointment was improved. So that was very reassuring. I'll say one of the very interesting things about this market is that these technologies are all going to get better every day, just like everything we've been talking about, because they just use data and they get better. But something that will distinguish AI scribes is when they're deeply integrated with our EHR, because as we know, workflows in clinical medicine are very important. So we've implemented one AI scribe so far at UCSF, and we have seen statistically improved same-day encounter closures. There's some incremental time savings that we've maybe seen. It's not statistically significant yet, but we're hoping it's real. But what's been really impressive is the feedback we've gotten, really compelling anecdotal evidence of improvement in satisfaction and cognitive burden. So these are just some of the quotes, mostly from physicians here. One is from a patient. Dr. X was testing a new AI program, which allowed him to speak directly to me. No typing, just eye to eye, simply spectacular. So the patients are actually liking this technology as well. But I think interestingly here, the devil's in the details. So note this quote. It's so impressive. I was nervous to use it at first. I'll be using it for all my new patients going forward. And so when we deployed this, we uncovered something very interesting, which is that people aren't as likely to use this for follow-up visits. And that's because when you're a clinician and you're seeing a patient in follow-up, you just copy forward your previous note and tweak a few things when you make changes. And so we have to build these types of learnings into our expectations around the return on investment of these products. And also, the technology companies have to learn from this, which they are, and improve the technology so they work in these different settings. So I also think generative AI is going to really transform medical record review broadly. And that fits into kind of two big buckets for me. One is just between providers. So imagine you're seeing a patient in clinic for the first time, you're admitting a patient to the hospital, and you have all the information you need already summarized. Our interns spend hours doing this. And then also for patients, summarizing things in various languages, various reading levels. Although, again, this is an area where even if the AI is really good at translation, we can't use it yet because of the regulatory environment. So we're going to be limited as we move forward because of things like that as well. So then the idea of trustworthiness came up. I won't go too deeply, but I'll say when I think about assessing these tools for trustworthiness, are they robust? Are they reliable? Are they fair? Are they doing what we think they are doing? Right now, for these keyboard liberation tools, I think of two kind of big buckets, and they're overlapping. One is the drafting, so that's what the AI scribes are doing. MyChart draft, patient message drafting, and then there's also the summarization features. And I think of them this way because I think about risk also as overlapping, but not totally identical things. So automation complacency. Errors of omission, I think, are really interesting when we think about summarization, right? Because if you have a human reviewing an AI scribe note, they're looking at the note, and when there's nonsense in there, they'll be able to edit it out, right? But if you're using these tools for summarization, the only way to know that it's missing something critical is to do that very thing that the entire purpose of the tool is to prevent you from doing, which is to review the patient's medical record. And so I think we have to be really thoughtful about how we measure that and how we identify those risks going forward. And then obviously hallucination and then bias, because the world is biased, the underlying data is biased. These tools just kind of regurgitate that. So this is one example of automation complacency that I thought was very interesting, where they basically proved it in a JAMA paper. They showed clinicians vignettes of respiratory failure with imaging, and they basically said, is this pneumonia, COPD, or heart failure, which can be kind of hard to distinguish clinically. And then they randomized these clinicians to either get a pretty good AI or a systematically biased one. And they found that, so at baseline, people were about 73% accurate in predicting this. When they got a good tool, they got 3% better. But when they got a bad tool, they got 11% worse. And so this is the first time being given this tool. It's not like they've been using it forever. We are just really prone to easily becoming reliant on these tools. And so we have to be thoughtful about that. And then the other thing we have to think about these tools is really how much we put into optimizing them versus the cost. And so these are the decisions you have to make. How good is good enough? Because when you put more data into these tools, these large language models are really expensive to run. And so we have to really balance optimization versus cost. So my colleagues in radiology wrote this paper about what we should learn from the 737 MAX disasters. Obviously, a malfunctioning AI system can have the opposite of its intended effect. Proper integration into the working environment is very important, as we've discussed. People using the AI need to be aware of the system's existence, and they need to know how to override it, right? And that's why the planes crashed. The pilots didn't even know the AI was running. And so that needs to be very clear. And then finally, what I think is very important here is the airline industry is very heavily regulated, but they're saying, regulation in that case wasn't sufficient to protect passengers. And so how are we thinking about that at UCSF? So we've built an AI oversight committee, and we have representation from across the board. We have health system leaders, we have health equity experts, we have ethicists, we have researchers, and they come together and they look at every tool that's going into the health system, regardless of where it's coming from. We don't care if the health system's buying it, if my health AI team's building it, or if researchers are building it. And we assess it according to our guidelines of trustworthy AI. And we've embedded these principles. These tools have to be fair, robust, private, safe, secure, transparent, explainable. We can get into what that means. I think that's also an interesting discussion. But all of those principles are embedded into how we assess these tools. And we've said no to things. We've said no to things that aren't accurate enough to be safe. So then the other component of this is, how do you do this long term, right? Because these tools are constantly evolving. And something that's really good today may not be good tomorrow. Our hope is it gets better, but that may not be the case. And even if the tool's fine, workflows change in healthcare, documentation practices change. And so we need a way to continually assess these tools. And so we were fortunate to get a donation to work on this at UCSF. And we're putting into place a system for longitudinal monitoring, thinking about how is the implementation long term, how is the model itself performing? That's what most people focus on, but I think it's actually not the most important piece. What we care about most in healthcare is what are the actual outcomes and impact on the health system. And so we're thinking about all those things together as important things to monitor long term. So remember, not all problems warrant AI. Just choose the right use cases. These emerging technologies come with trade-offs and unexpected challenges. I think we're going to continually have to do these cost-benefit analyses during tool selection, and the companies are doing it, we're doing it. And finally, once we decide on things to implement, we really have to assess the trustworthiness, both initially and long-term when we deploy in the health system.